Hello, everyone, and welcome to Pedirhythm. My name is Janette Strasburger, and today I'm going to be talking about mothers with long QT syndrome and fetal death. Thank you for allowing me to participate. I'm a member of the Heart Institute Children's Hospital of Wisconsin, and I have a few disclosures that you can read. The pregnancy education and care cycle actually spans many years of childbirth, and actually we don't usually see these patients when we want to. So it's important in the postpartum period, if you see a patient, to think about the next pregnancy and to pre-plan for that. And it's important when you're seeing patients that are teenagers in your clinics to realize that they are prepartum and to begin the process of looking at preparing those patients for pregnancy. The pre-pregnancy genetic counseling is important, and patients should see a genetic counselor for their family to review their family history, severity of the disease, whether there's been any reclassification of their disease recently that might affect whether they need to be on medications or not during the pregnancy. But in general, if a patient is on medications, they should remain on those medications during pregnancy. The inheritance pattern is usually autosomal dominant, and that's important because often we are referred patients because the mother has long QT, but it's somewhat forgotten if the father has long QT. So remember that whether it's father or mother, the infant will have an inheritance of autosomal dominant in most cases. So there are some hints that I'll go through later of how you might recognize a fetus that does have long QT, but just toss a coin and you'll be right 50% of the time. Reproductive options are important for patients to know about, such things as pre-implantation genetics that could eliminate the need for a baby that has long QT syndrome. But again, this isn't usually what most families opt for. Testing of babies can be done anytime, but it is invasive during the pregnancy, would require amniocentesis at minimum, and so most testing is done after the baby's born. Educational resources are really good at this point as the patient has time to read through these and think about them. And I would like to recommend that people look at this pamphlet that's been put out by the British, British, I'm sorry, this pamphlet has been put out by British Columbia, and it's really good, and it covers these topics. The topics are important and they're written in the language of the patient. So prepartum, there's also important early obstetrical counseling that has to occur, and this would be to review the potential for symptoms in the fetus and in the mother if she is affected, to discuss medications and breastfeeding. Some drugs are to the breast milk more easily than others, such as Nadolol. The high risk obstetrics is usually the preferred setting for at least initial evaluation of these patients. And so it's good to discuss the risks of home delivery and delivery in a low acuity setting. Nutrition is really important. We actually use a lot of these nutritional aids for treatment of patients with Torsade, and some of them are very effective. We're actually presenting with the group in Chicago the results of the use of vitamin D in one patient where we were able to restore sinus rhythm just by correcting the vitamin D deficiency. So specific circumstances are also good to address with a patient early in the pregnancy. Hyperemesis gravidum can affect the ability of the patient to keep down her medications. ICD events, QTC, prolonging drugs, all these should be discussed. Defibrillator care usually isn't changed during pregnancy. So throughout the rest of the pregnancy, it's also important to anticipate medical conditions of pregnancy that may impact the risk for patient and the medication she might be exposed to, and interact with some of the medicines she's on for long QT. Multidisciplinary care planning is really important, and it's important for the cardiologists participate in this regularly. And nursing input is ideal because of their ability to communicate with both the patient and the care teams. QT drugs I mentioned already, but some of them are very commonly seen and used in obstetrics. We can't get around Pitocin because it's often needed, but certainly being aware that it affects QT in high-risk situations is important. Anesthesia consults may be needed, and the delivery care plan should be put in the electronic medical record. If a cardiac arrest occurs, and it's actually less likely to occur during pregnancy than it is at other times in the patient's life, the cardiac arrest can be managed through the use of, defibrillation, isoproterenol, and if the patient's not responding, ECMO. Isoproterenol has been shown in one patient not to affect uterine blood flow, and oftentimes, if the fetus is viable, delivery is an option. So Bettina has an interesting study, which was a summary of a multi-institutional contribution, and this really refuted the former thoughts that there was no increase in risk in pregnancy for people with long QT syndrome, and that was primarily based on the old registry data that was largely long QT1. Now, what this newer study found is that stillbirths and miscarriages stillbirths were 8 times more common and miscarriages 2 times more common than in the general population. And it was a good mix of patients with KCNQ1, H2, and SCN5A. Not all stillbirths, though, carried the family gene, and it's possible that the long QT syndrome affects ion channels of the uterus as well, and that's going to be evaluated at some point in the near future with some research that's going on in Colorado. Genetic testing of fetal loss is important, and then these patients should have high surveillance during the 3rd trimester, with best done with biophysical profile rather than non-stress testing. So in this study, if the father was affected, the baby's weights were usually normal. If the mothers were affected, though, there wasn't any difference between those that were treated with a beta blocker and those that weren't, but the babies were smaller. So unrecognized de novo long QT syndrome, even in a negative family history, can be associated with stillbirth as well. Crotty's study in JAMA showed that there was a 3.3% incidence of known ion channelopathies and many more with ion channel dysfunction in the genetic autopsies. And our study on complex and novel arrhythmias preceding stillbirth showed also a high incidence of de novo long QT syndrome leading to stillbirth in 45%. So this is an interesting study of mothers and fetuses with outcomes in the treatment of long QT during pregnancy. And the question was, is natalol bad for the fetus? 64 pregnancies, not all knew they had long QT at the time of the pregnancy. Natalol was considered to be safe. It was as safe as other beta blockers. It was used in 60% of the patients, so it's by far the most commonly used drug. And the growth restriction was seen, but it was no more with natalol than it was with other beta blockers. Infants, no hypoglycemia and no and one patient had bradycardia. 5 events were seen. They were all in the postpartum period. The maternal syncope or sudden cardiac arrest were seen in and in those that had these events, it was up to 9 months postpartum, and 4 of the 5 had LQT2. So what you see here is those that were on beta blockers, 8 of the 20 total had IUGR, whereas only 3 of 20 of those without beta blocker had IUGR. So it wasn't considered statistically significant, but it's certainly been seen in many other diseases and probably also real. So the propranolol is seen more commonly in use in the postpartum period here because it doesn't get into breast milk as much, but overall natalol was the most commonly used. The reason again for the the non-treatment was because many patients presented in the postpartum period and were added to the study then. So delivery room care is important for the cardiologist to be part of, in the sense that we should be looking at the training of our nurses in ACLS. It's usually lower in the labor and delivery than in other ICU settings. It's good for your teams in your hospital that do resuscitations to run mock codes periodically in the labor and delivery area, and check the equipment, of course, because the defibrillators have to be useful for both mother and baby, and for both defibrillation and pacing. And ICD precautions may be needed if cautery is going to be used for C-section. This is just the cardiac arrest algorithm that came out in the 2020 version of the ACLS training, and this can be posted in the nursing lounge or in the labor and delivery area. So I'm going to switch gears a little bit and talk about the fetus with long QT at risk for fetal demise here, and this can be with a mother that's affected or not affected. So what I'll show are some of the symptoms that you may be able to pick up by echo. The first is the presence of an abnormal isovolemic relaxation time that was found in many patients at all gestations in the CLUR study, and this I always measure these. The long QT presents often with fetal bradycardia, and in this setting you can see that that most of them will have rates above what the obstetrician might consider bradycardia, which would be below 110, but below the 3rd percentile. So we really should be encouraging our obstetricians to take heart rates and measure them below the 3rd percentile rather than to call bradycardia less than 110. So that way we won't miss all of these that are between 110 and the lowest end of the rung. So sinus bradycardia, Binder was the first to really suggest, one of the first to suggest that it could be a common thing in pregnancy, and 12 of the 17 patients that he reviewed the prenatal data on had significant sinus bradycardia, and 2 of them also had tachyarrhythmias. In our recent review, Dr. Cuneo and I are looking at all of our sinus bradycardias, excluding those with other diseases. The fact is that 80% of those that have been referred to us with sinus bradycardia have come back positive for the ion channelopathy. So if they're not going to get an FMCG during fetal life, they at least need to have an ECG postnatally. You'll see later, though, that sometimes the QTC can shorten up substantially postnatally, and that can make it more difficult to diagnose postnatally than prenatally. So 2-to-1 and 3-to-1 second-degree heart block are shown here in the M mode, 2 atrial, 1 ventricular. And it's a little hard to detect 3-to-1 block, but here you see 3 atrial beats for every ventricular beat, and this actually is a tip-off when you see 3-to-1 block. The rates are often really slow in this setting, so it's tempting to start terbutaline, but if the patient's isoimmune, if the patient is not isoimmune, I would really discourage it, because so many of these are long QT and terbutaline has been proarrhythmic in long QT syndrome. You can also sometimes by echo see a mechanical alternans, a systolic alternans of the ventricle, and that's usually due to the QRS and the T-wave alternans that's occurring. And you will also see these late PVCs. They're late coupled, and because they're late coupled, they tend to trigger the torsade very easily, and we have a paper that's going to be coming out soon, hopefully, with that information in it. So again, torsade is seen with familial conditions, but we've had no mortality in that setting. With de novo cases, we have had more mortality, but LQT2 and 3 are more likely to have torsade. So the contribution of FMCG is really dramatic, and I won't discuss this paper, but I will discuss a little bit of the information from the paper about torsade. So in the cases in which we found torsade, 7 of 9 were not recognized by fetal echocardiography. And that's because the valve doesn't open and there's no flow, and so it doesn't look like tachycardia. You can see here, these are, 200 millisecond timelines that you would not think that this is tachycardia, but in fact, it can look like a slow sinus rhythm or sinus bradycardia with ectopy, or a lot of times if it's transitioning back from second degree block into torsade, you'll think that it's just a sinus rhythm. So high drops can occur in this, and as I mentioned, turbulene is quite prorhythmic. So it's important to treat torsade in utero, even near term gestation, because you can stabilize the baby before delivery. IV mag is the drug of choice, lidocaine, mexilotine, and of course the beta blockers are the main treatments. Propranolol is better transferred across the placenta, so probably is much better to use in this setting of acute management. It's important to look for any QT prolonging drugs that might be contributing, and methadone should be on this list for sure, as are some of the sedatives. 100% of control of torsade is not needed in order to see a decrease in the high drops and in order to manage the pregnancy. And in fact, it's really hard to achieve 100% control of torsade in utero. So in this setting, it's better to treat, but not to, again, you can't be too negative about the prognostication, other than perhaps in the setting of LQT3, where there's really a quite poor outcome in general across all age groups. This was from Jeremy Moore's paper. And this is just the fall this is the freedom from cardiac events in the LQT3s versus the others. And then again, the freedom from death by 50%, by 15 years of age, there's really only 50% survival. And we also have seen, as I mentioned, shortening of the QTC in babies with LQT2, 3, and the rare or double mutations, but not in LQT1, maybe because they already have a little bit shorter QTC interval anyway. But again, it is easier to make the diagnosis prenatally. These are just some examples. This is a heart rate trace over 600 seconds here, 300 to 600 seconds here, showing the torsade at the end at 2-to-1 block. And again, this is a burst of paroxysms of torsade. And this is what it looks like just with a single continuous rhythm strip. And this is the T-wave alternans that also affects the QRS duration and can cause the second degree heart block. This is the highlights of this study today that I've talked about are that the mother with long QT requires specialized care before, during, and especially after pregnancy for up to 9 months. Mothers have a high risk of stillbirth and miscarriage, higher risk compared to the general population, and are more likely to have, interestingly enough, female fetuses with long QT for some reason. And fetuses with long QT syndrome or the LQT related arrhythmias, the FMCG is very useful in detecting long QT and also the arrhythmias associated with it. The fetal bradycardia was seen with and without family history, and is usually due to inherited arrhythmia syndromes, and it's usually not due to beta blocker therapy. And finally, torsade should be treated in utero to stabilize the infant prior to delivery. Thank you. I'd be glad to take any questions.